All right. Well, welcome back from lunch, everybody. I hope you had a great break and got your bellies filled. Thanks for joining us for this session. Before we get started, just a couple of reminders. First, I want to thank all of you for attending. And again, I want to thank all of our sponsors. We couldn't be here without them. So thank the sponsors if you get a chance. Please use the chat feature or the Q&A feature to ask questions of our speakers anytime during our session today. We'll be monitoring those chats and letting our speakers know. We'll also give you some time for Q&A at the conclusion of our speakers' presentations during the session. So welcome to Keep It Secret, Keep It Safe, our session on security and technology. In this session, our speakers are Justin Cole with Garlington Lawn Robinson Law Firm out of Missoula, Montana, and Deb Anderson, who is the Health Information Technology and QI Consultant with Mountain Pacific Health. We're going to be covering patient privacy and security, some Big Sky Care Connect legal documents, liability, and data quality today. Before we hear how we're going to keep your data and our patients' data secret, keep it safe, it's my pleasure to introduce our first speaker, Justin Cole. Justin concentrates his practice in health law, advising hospitals, independent practice groups, and individual practitioners on a number of health law compliance issues, including HIPAA compliance, HIPAA breach analysis, and reporting EMTALA, Medicare, and private insurance reimbursement, Stark and anti-kickback contracting matters, among other issues. Justin also works with hospitals and medical staffs regarding medical staff bylaw issues, peer review, credentialing, and other issues affecting the medical staff. So with that, I will say thank you and turn it over to Justin.
Thank you, Kurt. I'm going to go ahead and share my screen. Okay, and thanks again, everyone, for tuning into this track, Technology and Health Information Management, Keep It Secret, Keep It Safe. I appreciate the introduction and certainly won't repeat it, only to say that our law firm here in Missoula, Garlington Lawn Robinson, we're really dedicated in large part of our practice to defending, supporting, and promoting healthcare organizations across the state, including hospitals, physician groups, individual practitioners. Very grateful for this opportunity to be here with you today, be involved with Big Sky Care Connect. It's a very exciting, forward-thinking venture. It's really a privilege to be a part of it and to be here speaking with you today. So we'll get started. Today I'm going to be talking about, there's two sessions here, there's two sections to this session. I've got about 45 minutes to talk to you about the fundamental legal structure of the HIE and some legal concepts, some laws that apply both at the federal and state level, and how the HIE is designed to comply and promote compliance with those laws. This is going to be an overview in nature, and I want to save a little bit of time for some Q&A. Feel free to raise questions throughout or at the end. We certainly could spend all day on this topic, and while I'd love to do so, I'm sure you wouldn't. And I want to leave time certainly for Deb Anderson on the second half, who will talk more practically about the data and the how and why and how this data will be used. But this is where we're going. We'll talk about HIPAA, basic rules. We'll talk about the basic structure of this network, question of opt-in versus opt-out, a big question with some clear answers and guidance as clear as it can give. Sensitive data and how sensitive data is handled in the network. We'll have a little discussion about the new information blocking rule, not a lot, and then talk about data aggregation and what that means in some various contexts. So let's start with HIPAA. And I want to start this presentation as I do with discussing this topic and discussing the HIE in general, and that's that the basic rules are the same. HIPAA doesn't change when we talk about exchanging data through the HIE. Those basic rules that we all know and that we're all accustomed to apply. They apply when we are using a telephone. They apply when we're using a computer or an EHR, when we're sending emails, fax machine, faxes, or information exchanged over the HIE. The medium over which you exchange data doesn't change the rules. And that's a really big topic that I'll probably be coming back to, and you should too in your mind, because the HIE doesn't expand the law. It doesn't change the law. Instead, it works within well-established privacy and security standards under HIPAA and other applicable law. So let's talk a little bit about HIPAA, and it's certainly anyone who's tuned in here knows about HIPAA and doesn't need a primer on HIPAA, but it's important to go back to these basic rules, particularly as we look at how this HIE is structured and why it's structured in the manner that it is. I've got one slide on HIPAA, and this presentation and many more of it could be entirely about HIPAA as we know. But HIPAA, the Health Insurance Portability and Accountability Act, set those standards, those uniform standards for privacy, security, and availability of health data. It deals with PHI, protected health information. We know that that's individually identifiable health information that relates to individuals, past, present, or future, physical or mental health, the health care you give to that patient or the payment for that health care to that patient. And I start with that definition, of course, because that's the data that we're using in the HIE. That's what the HIE deals with at all levels. HIPAA establishes the privacy rule and the security rule. Privacy rule, of course, which deals with the use and disclosure, allowable uses and disclosure, and confidentiality of PHI. It establishes the security rule, which deals with confidentiality, security, and integrity of electronic PHI. Again, both apply to what the HIE is all about. The standards and requirements of HIPAA apply to covered entities. Covered entities are payers, health plans, healthcare clearinghouses, and of course, healthcare providers, all of which use and exchange patient health information. And I identify again, we all know the definition of covered entity, but that's the users of the HIE. Again, at all levels, the HIE is designed to comply with and promote compliance with HIPAA. So how does the network comply with HIPAA generally? And we'll get into a little more specifics as we move forward. But from a privacy perspective, the network allows participants only to exchange information in a manner that HIPAA already allows. The uses of the system are restricted to uses that are currently allowable under existing federal law. Things like treatment, payment, and healthcare operations, those are disclosures for which no specific consent or authorization is required. Public health reporting activities, other reporting required by law, and authorization-based disclosures, individual right of access. The HIE is designed to facilitate all of these uses, but allows no use which is not currently allowable under the law. And again, an important theme when we're talking about the structure. And how does it comply with the security rule? Well, it does so in a variety of ways, and again, we'll talk in more specifics as we move through the presentation, but it engages in robust security requirements in the design of the network and also expectations put on the network, but also on the expectations it puts on its participants to have its own and their own robust security protocols. It has secure encryption methods for all of the data at all times, at rest and in transit. We've been talking about the structure of the HIE, and the fundamental structure is a consolidated, centralized repository model. This is a model in which participants share data into a centralized warehousing system. The data is stored utilizing standardized universal data storage format criteria, HL7 and other national standards. And this type of model really is designed to allow for a multifaceted use of the health data. It allows the network to grow and increase its value to its users over time, all while remaining course HIPAA compliant, complying with applicable law. The centralized repository model allows flexibility for the use and exchange, disclosure of the information. It promotes interoperability, another key theme. And it equips the HIE with the ability to develop tools that will be for the benefit of its stakeholders. Ultimately, it continues to further and promote the health of our Montana citizens. Second point, it's underpinned by a robust and secure architecture, which is hosted by InterSystems. It's a secure platform. Again, the data at all times has end-to-end encryption. It's encrypted in motion and at rest, all again to allow and promote the secure exchange of information in a robust manner. So this notion that I'm developing and trying to really get across is that the HIE is nothing new. Of course, it's everything new, and it's an exciting forward-thinking way to think about health information exchange of actual data for real good reasons. But it's nothing new because it doesn't change the rules and it doesn't change the law. You can analogize the HIE to a fax machine, but one that is very complex, high-tech, data-rich, and delayed in transmission. And what I mean by that is the transmission of that record, though housed in a centralized data repository, is only complete when the end user queries and accesses that data for a permitted use, with all consents, obtained and approved. It is as if a medical provider made thousands of faxes and sent them out only to be transmitted to the right person at the right time, all in a manner compliant with HIPAA. So how do we accomplish this? How do we accomplish something so complex that doesn't change the rules and is supposed to be like a fax machine? Well, we do so by engaging the participants in a contractual arrangement with the network, and that's the participation agreement. More on that in a minute. We also establish at the network policies that the network has to comply with and that all participants need to comply with. And what this creates is a consistent, level playing field that's the same for all users and complies with all applicable law. The rules of the road, if you will, are the same for everyone. So the participation agreement establishes the requirements on the participants. The major one is to comply with the law and to only use the network in a manner that complies with the law. There is that contractual obligation that's made between the participant and the HIE to ensure that these agreements and these commitments take place. The participation agreement further places security standards and requirements and establishes the relationship by and between the participants and by and between the participant and the network. There's a business associate agreement that is a part of the participation agreement, and that permits the exchange of this information to be facilitated through Big Sky Care Connect as a business associate. In that regard, the network is a facilitator. It facilitates the exchange of information by and between the participants, and that's its primary purpose. The policies, again, establish at all times everyone needs to comply with applicable law. And again, it does so in multiple ways. One in particular is the permitted use policy. The policies of the network allow uses only for expressly permitted purposes. And those express permitted purposes are those that are already allowable under applicable law. Again, a lot of themes, and I understand that, but it's important to understand how the network is designed to be compliant. There are also policies on usage and auditing of and monitoring of the system. There are policies that apply to authorized users of the system, specific requirements. There's required training on participants to comply with HIPAA and understand and know the rules. There's password requirements, complexity requirements, detailed requirements to ensure secure exchange, among many others. These just set the rules, requirements, and expectations of the participants engaged in the network. So how do you manage these goals? You do so in numerous ways. It starts with the design. You design a secure system, both from a technical security standpoint to keep data safe and secure at all times, but also from an architectural standpoint, whereby the system itself, the environment, the flow, is designed to encourage and promote lawful and appropriate exchange. You then have controls in place to make sure that everybody follows the rules of the road. You set those rules, you set them in compliance with the law, and you require everyone to follow them, to follow HIPAA and to follow the rules with respect to engaging with the system. And then you follow it up, and the last piece of the puzzle is monitoring. There is activity that is monitored by the system to ensure that participants are using it appropriately, complying with the rules, and complying with the law. So how does the minimum necessary standard of HIPAA fit into the HIE context? Does the HIE and does its users and participants follow the minimum necessary standard? And the answer is yes, of course it does. Again, the minimum necessary rule applies and is not changed in the HIE context and should bring that sense of comfort to the users. The minimum necessary standard, of course, requires the use and disclosure be limited to the minimum necessary to accomplish the intended purpose, to limit unnecessary access to an individual's health records. Applies with equal force when you're engaged in exchange through a health information exchange. There are exceptions, and the exceptions include treatment-based disclosures, authorization-based disclosures, disclosures required by law, and individual right of access, an individual seeking their own medical records. The HIE is designed to accommodate all of those uses, all of the exceptions to the minimum necessary standard, but applies the minimum necessary standard with equal force as it applies to us all under HIPAA. It's a common source of concern and anxiety that I hear from prospective users or people hearing about the HIE, but again, these rules apply throughout, and it's the reason why I keep repeating it, because it is so important. Just a short note that the network is designed not only to comply with the law, but to comply and be consistent with the growing and evolving HIE industry. It's structured to be consistent with other national data exchange platforms, such as the eHealth Exchange and the Data Use Reciprocal Support Agreement, the DRSA, as well as other national platforms to scale and the reach of this information exchange beyond our Montana borders. Let's take a minute to talk about meaningful choice, opt-in, opt-out, and do patients need to affirmatively opt in to have their records exchanged over the network, or does it require an opt-out? And in Montana, the answer is opt-out. This network engages in an opt-out model. That's the arrow flowing to the right. And the reason for this is many. First, Montana doesn't have specific legislation that requires an opt-in or opt-out structure for health information exchange, as is in other states. And so because of that, in the absence of a specific law, HIPAA allows and permits an opt-out model, provided that at all levels the exchange is HIPAA compliant. So what does an opt-out mean? An opt-out means patient information and data can be exchanged through the HIE unless a patient specifically indicates to the network that he or she does not want to participate in that manner. This doesn't change the requirement for participants and providers to provide meaningful choice to the patients with whom they treat and exchange their information, and to obtain appropriate authorization and consent, as you would in all contexts, but to engage in health information exchange. That doesn't mean it creates an opt-in requirement. So how does a patient opt out? Well, there's a straightforward and rather simple process to do so. A participant can opt out directly through a participant, through a provider, which has been forwarded to the HIE, or can do so directly with the HIE itself through the website or by calling and requesting an opt-out form. That opt-out form is filled in, and then the appropriate mechanisms take place to ensure that patient is opted out. So what's the effect? What does that mean? Well, it doesn't mean that the data comes out of the system, and it doesn't necessarily mean it stops going in. But what it means is that that patient who is opted out, their data is no longer viewable, readily viewable in the system. We use this term, it's behind glass, and that'd be an opaque glass that can't be seen or viewed. But it can be used in certain circumstances, and that's why it stays in the network. It can be used in emergency situations, and this is a situation where someone is opted out and is then later in need of emergent care, and the records will be accessible by a provider in certain limited circumstances, again, to promote interoperability, but further healthcare and the delivery of healthcare to our citizens. It can also be used, the reason it stays in the system, just hidden, is it can be used if a patient changes their mind and they want to opt in or rather revoke their opt-out of the network. And when that's done, the information is again immediately viewable and immediately accessible. That opt back in or revocation of the opt-out can take place same day, it can take place immediately, and there are mechanisms in place whereby if a provider understands that there's additional important records in this system, can obtain that consent from the patient and access those records. Keeping an eye on time, I don't want to take up Deb's more valuable time. Let's talk about sensitive data, and not all of the records that we exchange can be exchanged in a free-flowing manner. And when I talk about sensitive data, I don't mean data that is sensitive based on the nature of the health record necessarily. Indeed, all PHI is sensitive and can only be exchanged in a manner compliant with HIPAA. But when we're talking about sensitive data in the context of the HIE, we're talking about it as a term of art. And sensitive data is that which the law, either state or federal, requires a specific level of consent before the data can be exchanged, or there are other specific ways the law handles this data. So how is sensitive data handled in the network? Well, before the data comes in, it is identified and marked as sensitive before it goes into the system. And this is a requirement on the participants to ensure that the data that needs to be treated as sensitive be marked before it goes into the system. Once marked, it's electronically tagged by the system and then maintained electronically behind that glass. It's maintained in a manner where it's not easily viewable. It's not viewable, readily viewable or accessible by a provider unless an affirmative action is taken. How do we handle consent? Consent is handled by having two layers of consent. Consent to get the record into the system, and then consent for it to come out. So we require, of course, the participants to comply with the law and obtain appropriate consent. And for sensitive data, that requires consent to put it into the network. And then on the second level of consent, if a provider does have authorization and consent to view that sort of information, that provider can do what we call breaking the glass, can take out a hammer and break the glass and view the information. It is akin to and analogous to a provider talking to the patient, obtaining a consent form, redoing it to be consistent with what the other provider who created the sensitive information needs and likes, sending that request, and then having the record sent over to you. It's that same process, the data is just already in the system. And that's another example of how the HIE can be so efficient with lawful and compliant exchange. Of course, on this functionality, while it can be done with that affirmative representation by the provider seeking the information by saying, I have a consent, there's those controls in place and the monitoring to make sure that that's being handled appropriately. I might go a little quicker through here just in deference to the time. Types of sensitive data are 42 CFR Part 2 substance use disorder records. These are records that identify an individual as having a drug abuse or a substance use disorder by a federally assisted Part 2 facility or provider that primarily holds him or herself out as providing substance use disorder treatment. That law requires specific consent even for treatment and payment purposes, and which is why the records need to be handled in the manner I've described. It permits disclosure without consent in limited contexts, one being bona fide emergency purposes, and the HIE is structured to accommodate that use as well. One note is that the CARES Act, which went in place earlier this year, has a component that will be effective March of next year, which will change these rules somewhat, in we hope significant ways, to not require that dual level of consent, but rather to require an initial consent and then reuse and redisclosure based on treatment, payment, and healthcare operations. As the law stands, there's strict prohibitions on redisclosure. So quickly, HIV and STD, these are creatures of state law. Montana state law defines and provides some consent requirements, written consent requirements on the handling of HIV and STD or STI records. Not a model of clarity, and so the network has taken the law that is, and the network has taken a conservative approach to treat these records all as sensitive, meaning it requires that dual layer of consent. Psychotherapy and notes that I won't dwell on, but under the definition of HIPAA are mental health professionals, individual notes, not part of the medical record, which are separately maintained. HIPAA has heightened security requirements over psychotherapy notes. So the way the network handles this is psychotherapy notes are not to be exchanged to the system. So you think, okay, sensitive data, I've got liability if I exchange sensitive data not in compliance with the law, so I won't do it. I won't do it, or I'll overly market and just make sure the network keeps it all behind glass. Well, it's not quite that simple, because we now have this information blocking rule. Again, in furtherance of interoperability, these new rules were put out to not allow certain actions or activities that might be considered information blocking, and it further creates and increases the complexity of the balancing act that the HIE needs to strike. So what is it? It's information blocking is defined as a practice that is likely to interfere with the access, exchange, or use of electronic health information. The compliance date keeps getting pushed back. It's now April of next year when everyone needs to come into compliance. Who does it apply to? It applies to, for our context, health information exchanges, but also applies to providers. And there are differing standards. For the health information exchange, the standard on whether you're engaged in an improper practice is a know or should have known standard that a practice is likely to interfere with that free flow of electronic health information. Providers have a little more deferential standard. You'd have to show that the provider knew that a practice was both unreasonable and likely to interfere with, prevent, or materially discourage that exchange of information. There are numerous exceptions to the information blocking rule that apply to not fulfilling requests or procedures for fulfilling requests. And the HIE is staying up to date on this law as it will be evolving to make sure that its practices comply with this legislation. Data aggregation, and this is going to flow into Deb's presentation here in just a few minutes. What data aggregation is, it means different things in different contexts. Big A aggregation or little a aggregation, and what do I mean by that? Well, there's a difference when we're talking about aggregation or analytics of data. When we talk about one participant's data and analytics or aggregation of that data, when we're doing that, we're thinking of healthcare operations, permitted uses by that participant for that sort of use. And the HIE certainly is well suited and well positioned to provide services in that regard. But when we talk about big A aggregation or term of art to a healthcare lawyer, HIPAA has a specific definition of aggregation, and really what it is it's when a business associate takes one covered entity's data and aggregates it with another covered entity's data, provides analytics, and spits out de-identified results to both users. These are quality metrics, benchmarking sort of activities. HIPAA has a specific requirement. It says if a business associate is going to do that, the business associate agreement has to specifically permit it. What the network has done here in this current state of things is the BAA does not give that blanket permission at this point in time. So participants can rest assured that without their separate consent, their data is not going to be aggregated at this time with other entities' data. But this structure is in place to allow flexibility, allow individuals to consent, providers to consent for aggregation, to provide those tools for future beneficial uses, and then of course create the platform whereby in the future we can get to data aggregation on a broader scale. So I apologize, I'm not sure I left too much time for questions, but certainly happy to take them and then kick it over to Deb Anderson, and I'll stay on if there's questions after Deb's section as well.
So folks, if you have questions, please feel free to type them out in the chat, and we'll make sure Justin gets to those.
And I'm leaving Deb only 15 minutes, so please do put them in the chat. I'll watch them. But let me just give a brief introduction to Deb. She's going to talk about the data that's being captured and how it can be used, really the how and why to why the HIE exists to promote quality care. Deb works with Mountain Pacific Quality Health. She has 19 years of experience with health information technology and 30 plus with general IT experience. I'm sure she'll provide the more interesting and certainly more applicable half of the show. And so with that, Deb, I'll turn it over to you.
Thanks, Justin. I appreciate your informative and comforting presentation on keeping the patient information safe, specifically on how Big Sky Care Connect will be handling that sensitive data. You know, we all get really excited about talking about that data, and it's been there have been many, many conversations about that as we have met in our committee meetings. So I'm going to go ahead and share the data. And can I have a time check? I actually think we have quite a bit of time. Yep, we do. I knew we were scheduled for a little bit longer than the 45 minutes. So please, I'm happy if you have some great questions for Justin, because I have like lots of fun information, excuse me, but it'll take us a while to get through it. So with that said, I want to welcome everyone. And I want to make sure you've got plenty of caffeine for the second half of this section of our session today. If you need a seventh inning stretch, please feel free to take advantage of being virtual and do your chair yoga or your stretches while I cover the commercial messages. As Justin already mentioned, the second half of this breakout session is a review of the data we are capturing in electronic health records and the standards that impact both quality reporting and successfully exchanging the data. I plan to provide information today to lay the foundation for understanding how to bring together accurate and complete information to report the quality care being provided in Montana as well as ways to use data to identify patients at risk, the gaps in services or care, and the improvements in sharing of data for the continuity of care. I hope this is meaningful enough that you have many questions for our subject matter experts, and you can put those in chat or Q&A, I guess, on this case, and we can address them today or maybe even in a future education session. I would also like to thank the Big Sky Care Connect committees and team for all of their tireless efforts in moving health information exchange forward in Montana. We have been on this journey for some time, and it is exciting to be off to the races very soon. We continue to receive invaluable support from partner health information exchanges, and I would like to acknowledge the assistance that I personally received in preparing for this presentation from our neighbors in Idaho, Utah, Wyoming, and Nebraska, as well as other HIE subject matter experts on the Big Sky Care Connect team. It is truly amazing to work in such a collaborative environment with those who are passionate about transforming healthcare. So a bit about Mountain Pacific Quality Health. We are a nonprofit healthcare improvement organization that partners within our communities to provide solutions for better health. We first opened our doors in Helena, Montana in 1973. Since then, we have broadened our reach to include Wyoming, Alaska, Hawaii, and the U.S. Pacific territories of Guam, American Samoa, and the Commonwealth of the Northern Mariana Islands. I'm honored to be part of this amazing team working across our region and nationally. Many of our contracts are from Centers for Medicare and Medicaid Services, or CMS, and include support for quality reporting programs like the Merit-Based Incentive Payment System, or MIPS, the Comprehensive Primary Care Plus, CPC Plus, for providers, as well as various hospital reporting programs. In addition, we are currently under contract with the State Departments of Health in each of the 4 states to support the 1815 chronic disease prevention work funded by the CDC. So today we're going to explore many pieces of the data puzzle in healthcare with one overall objective, that is to complete the data picture to report the quality care being delivered. We will also explore how the pieces of an electronic health record may be different than the pieces of data or data sources in a health information exchange. Which one is better or more complete? I think that's for you to decide. I do have to apologize in advance for the number of acronyms used. I've done my best to use a full name and then list the acronym, but at the end of the presentation, I've added a list of acronyms for your reference should you want to download the presentation. My goal is to provide you with enough information to be knowledgeable, or what I call dangerous, but not enough to jeopardize my job security. So many of us recognize the challenges in working with healthcare data. The amount of data is staggering. The varied types of data which are available to healthcare in healthcare continue to grow exponentially, and the exchange of data can be challenging even in the simplest connection. By now, you may realize that I was a Star Trek fan, since I will pronounce this as data versus data, which is apparently the correct US pronunciation. So standards are critical in the process of capturing, utilizing, and sharing data. We have been on a journey in healthcare to create, implement, and update standards for many years, and the road is long and the process has its challenges. On May 19th of this year, the National Quality Forum, or NQF, released its draft report on an electronic health record data quality best practice project, which was funded under the contract with the Department of Health and Human Services. The project aims to identify challenges that impact the development, endorsement, and implementation of healthcare performance measures that use EHR data and recommend actions for mitigating those challenges. I will review more on the project in a few slides. So I do realize that I'm hoping we have some of our health information management professionals on the session with us today. And being in Health Information Management Systems Society, I've learned the importance of the partnership with those folks who are in charge of the health information at each of our facilities as well. So In your honor, I went out and found some information from the American Health Information Management Association, known as AHIMA, and in a 2004 report titled Standards for the Content of the Electronic Health Record, they listed these advantages for the use of the EHR data's standards. So those include providing the clear description of the data elements that will be included in an EHR, identifying the essential data elements, such as temperature and blood pressure, standardizing the field links, the data types, the content of each field, each data field, improving the data granularity, which is important, and we'll talk about that a little bit more as well, accommodating various degrees of granularity in the record, accommodating both structured and free text reporting, relating major entities of the record to be identified in specific segments, matching data elements across systems for extensive patient care reporting, overall improvement in the quality of patient care, and the development of a longitudinal health record. The introduction of the study, the authors noted that the emergence of the EHR brings anticipation about future uses, including the sharing and exchanging of information among divergent systems. A major issue that needs to be addressed in order to accomplish this sharing and exchange is the development and use of standard data elements and content in the electronic health record. 2004. So fast forward 16 years, and the need for standardized data is more critical than ever as we look forward to exchanging our data across the state of Montana. So, electronic health records, the EHRs. Much of my work at Mountain Pacific has focused on implementing certified electronic health record systems and helping organizations to meet the meaningful use requirements for incentive payments. We have experienced numerous challenges with the EHR vendors, the workflows, and what providers will say were way too many clicks along the way. This program is now called Promoting Interoperability, and the requirements for attestation have changed. While I would like to tell you that this reporting is less burdensome and truly makes sharing information across platforms seamless, that isn't what most of our organizations experience. In a later slide, we'll talk about direct messaging as a method of information exchange. This is a method that supports the notifications described by Tom Novak in his presentation this morning. This healthcare-specific form of secure email was part of certified EHR technology starting in 2014. Here's my fax analogy. Asking providers or organizations for their direct address or secure direct email address for stage 2 of meaningful use was really like asking them for a fax number when only a few had fax machines in their offices. Most really didn't understand what we were asking for or even why it was important. The Certified Health IT Product List, or what we fondly call CHAPL, continues to be an important reference when reviewing the certification criteria for the electronic health records, as well as the clinical quality measures, or CQMs. The EHRs are certified to report, and I'll have some examples of that on the slides that follow as well. So I wanted to share a bit from the EHR data quality study with you and have added the link for those who have inquiring minds and wish to either read the environmental scan, which is only 36 pages, or the 33-page draft report for public comment. Here is a direct quote from the executive summary from the environmental scan. Although electronic health records, or EHRs, are primarily used to support patient care and medical billing, their alternative use as a data source for clinical quality measure can be potentially improve quality measurement. To better understand this potential, it is important to examine the current state of EHR data quality. The project aims to address the challenges that impact the development, endorsement, and implementation, and again, address mitigating those challenges. So further along in the environmental scan on page 5 under scanning results and analysis, it says that the performance measure usage in the inpatient and outpatient settings rely on a variety of data sources. We're going to talk a lot about data sources. So these include claims, registry, and EHR systems. As a result of the Health Information Technology for Economic and Clinical Health Act of 2019, we call that the HITECH Act, and the EHR incentive programs, 4 out of 5 office-based physicians and over 90% of hospitals now use their ONC certified EHR systems. And if I forgot to tell you what ONC means, it is the Office of the National Coordinator. The ECQMs, or electronic clinical quality measures, were seen as a chance to take advantage of the new opportunity presented by the growing adoption of the EHR system. While many challenges impact the performance measure development and the endorsement and the implementation with the EHR data, the challenges related to ECQMs are unique since they are the primary settings where the ECQMs have been adopted. The promise of ECQMs has built on the foundation of structured data from an EHR system and other health IT systems to enable automated quality measurement. This was not possible in the days of primarily unstructured patient records. And last, on page 6, the EHR data requirement and measurement criteria contained within the electronic clinical quality measure are not always aligned. This is not unique to ECQM standards. Many HL7 standards have data model alignment issues with structured EHR data. So also think about when you are talking about issues within the EHR, those are potentially challenges we're also going to face if we're looking at reporting quality data out of a health information exchange. The HL7 standards in general have faced issues aligning with actual structured data and have presented an initial steep learning curve to implement. Furthermore, aligning data from your EHR systems to be usable for EHR-based measures always requires some degree of data transformation. The need to address data alignment and the ease of implementation issues has contributed to the industry-wide push toward the development, maturation, and adoption of the FAST Healthcare Interoperability Resources, or the FHIR specification. So don't get too excited yet. We won't talk about FHIR for several more slides. All right, so the Certified Health IT Product List website is overseen by the Office of the National Coordinator. And this is what the site looks like today. It's undergone some updates and changes over the years. And my fair warning to you, if you want to go out and play, the best time to use this site is before attestations open in January. The closer to the reporting deadlines, the slower the site becomes. What I find interesting is the site now lists information on banned developers, inactive certifications, decertified products, and products with corrective actions needed. But it's still primarily used to verify the certification IDs that we need for hospitals and providers to attest to the reporting programs like promoting interoperability, or the old meaningful use, or the merit-based incentive payment system, MIPS. There are also enhanced search filters, including certification status, certification edition, like a 2014 or a 2015 certification status, the actual certification criteria, the surveillance activity, or other filters which allow for improved product location and comparison. Other Chapel site items of interest include the Application Program Interface, or API information. You'll be hearing a lot more talk about API and FHIR APIs as well, but there is information that talks about the categories that can be applied to the APIs, and those are usually application access measures or measurements criteria, including patient selection, the data categories, and all data requests, or the API for patient population services. And last, we find the SED information for 2015 edition products. So Safety Enhanced Design, or SED, is relatively new, And the health IT developer or EHR vendor can submit documentation demonstrating that the user-centered design processes were applied to all of the safety enhanced design certification criteria. A little bit interesting, and if you want more information on that, please feel free to pull up specific information behind the SED button on the Chapel website. Here is an example of the information available on the site for Certified Electronic Health Record. This is a provider EHR, and you can see it has a Chapel product number. It also has the certification ID. It has a certification date. And unfortunately, my slide cut off a little bit because really what I wanted to highlight here was the number of certification criteria that the application has met, and also the number of clinical quality measures that the application has met. In the early days, we had a lot of EHRs only able to report the minimum necessary clinical quality measures, 6, 9, 12. Now we have several EHRs that can report up to 64 or even more of those certified quality measures. Okay, here comes the fun stuff. Well, for some of us anyway. The health information technology and data standards that are important in recording and reporting information technology. There are many, and we will look at a few of them today. So it's important to understand that the National Library of Medicine is the central coordinating body for clinical terminology standards within the Department of Health and Human Services, or HHS. The NLM works closely with the Office of the National Coordinator for Health Information Technology, or ONC, to ensure that the National Library of Medicine efforts are aligned with the goals of the President and HHS Secretary for the nationwide implementation of an interoperable health information technology infrastructure to improve the quality and efficiency of healthcare. So many of you hopefully have heard of some of these acronyms, but the Logical Observation Identifier Names and Codes, commonly called LOINC, is really about the medical laboratory observations and its terminology. It's also been expanded and includes nursing diagnosis, nursing interventions, and outcomes classifications, and patient care data sets. Some of these standards date back to 1999 and have been in use for several years. Those of you who have done any type of setup within the EHRs are relatively familiar with the LOINC codes, and you will see in a little while how those codes are as important in pulling out information for quality as reporting as it is for putting the information into the electronic health record. So the RX norm is the US specific terminology in medicine that contains all medications available in the US market. It's part of the Unified Medical Language System, or UMLS, terminology, and it is maintained by the United States National Library of Medicine. SNOMED Clinical Terms, or SNOMED CT, is a systematically organized computer processable collection of medical terms. Wow, say that 3 times fast. It provides codes, terms, synonyms, and definitions used in clinical documentation and reporting. SNOMED CT is considered to be the most comprehensive multilingual clinical healthcare terminology in the world. The primary purpose of SNOMED CT is to encode the meanings that are used in health information and to support the effective clinical recording of data with the aim of improving patient care. SNOMED CT provides core general terminology for electronic health records and includes the clinical findings, symptoms, diagnoses, procedures, body structures, organisms, and other ideologies, substances, pharmaceuticals, devices, and specimens. Again, the Unified Medical Language System, or UMLS, is a compendium of many controlled vocabularies in the biomedical sciences. It provides mapping structure among these vocabularies and thus allows one to translate among various terminology systems. It may also be viewed as a comprehensive thesaurus of biomedical concepts. As indicated on the slide, it integrates and distributes key terminology, classification, and coding standards and associated resources to promote creation of more effective and interoperable biomedical information systems and services, including the EHRs. So what does that tell us? That tells us that unlike certain data systems, unlike certain systems that we see on the internet, it's not really as easy as a banking system where there might be a single credit or a single debit. We have so much information, we have so much data, we have to have the standards to help us utilize the data, report the data correctly. Also, in our EHRs, we use it to request or ask in the assessments what is the appropriate data. We record the data so that we can do some analysis within our EHRs or in other analytic systems. We use the terminologies to map our data, and last and most importantly in my world these days is to report that data out for quality improvement. So there are several steps to setting up quality measures in your EHRs or other reporting systems. For those of you who like the nitty-gritty details, may I recommend a visit to the Electronic Clinical Quality Improvement Resource Center, or ECQI Center, at healthit.gov. Here's a simple example of the LOINC, the lab terminology code used in the setup of the quality measure for preventative care and screening for an influenza immunization. Now that we've talked about the data standards in the EHR that support the quality reporting, here's what I think is really the bottom line for me between the EHRs and the HIEs. And that is the EHR data is within the realm of that provider. Now granted, we know with some health information exchange, we could pull in data from other sources, and many folks are doing that and doing that successfully. But when we use the standards and the mapping, we can add that data in from one EHR to another EHR, patient by patient. So that's a lot more burdensome when we're talking about accessing and pulling in a patient's record and reconciling that one patient at a time. So the scanned or faxed data is generally not structured. So again, even though those fax machines may be great for securely transmitting the information, there's a reason that we need to step beyond the limitations of faxes. So each of those need to be manually reviewed, and if there's critical information about the quality of the care, a lot of times that has to be manually entered into a provider's EHR. The quality reports from a single EHR may not reflect a comprehensive or consolidated information that could be found in a health information exchange clinical data repository. So what about the data in the health information exchange? The terminology standards that we discussed earlier are even more critical in a system that can aggregate and analyze the data from multiple sources. Please remember what Justin shared in his presentation. Data aggregation will only occur when appropriate agreements and data governance allow it at Big Sky Care Connect. There may be an opportunity for current healthcare organizations to request aggregation and analysis of data within their single entity if they're using more than one EHR or have more than one location. It's also a possibility to use consolidated information to support innovations in payment models, like the Comprehensive Primary Care Plus, CPC Plus, or patient-centered medical home models. Communities may also want to create something similar to a clinically integrated network to help identify their patients who are at risk. Again, these are only examples of what could be done with the more complete and normalized data in a centralized solution. There are also very important interoperability standards to consider when transmitting data. There are some differences that can become important when we talk about the data needed for quality reporting. HL7 and its members provide a framework and related standards for the exchange, integration, sharing, and retrieving of electronic health information. These standards define how information is packaged and communicated from one party to another, setting the language, structure, and data types required for seamless integration between systems. HL7 support clinical practice and the management, delivery, and evaluation of health services and are recognized as the most commonly used in the world. So we're going to talk a little bit about the interoperability standards, including each of the HL7 standards. But what I would like you to focus on here, especially if you're a health information management professional, is how do we review and make sure that we are protecting the integrity of the data as it is being sent to an HIE or a clinical data repository, and how do we make sure that we're comparing apples to apples and not apples to oranges. So let's talk about direct. Remember that direct address that I was talking about earlier, and it was like trying to ask for a fax number when no one knew what a fax machine was? Well, direct the development of direct actually began in 2010, and it was a public-private collaboration with the backing of the Office of the National Coordinator for Health Information Technology. And it essentially is an email that, instead of being maintained by an organization or employer or email provider like Google or Outlook, Microsoft, it's maintained by a health internet service provider, or a HISP. The HISP carries out the encryption, decryption, and digital citing of each message and attachment. We do have direct addresses and direct messaging support with Big Sky Care Connect. So in November, Direct Trust announced that 197 million messages were sent and received within its network during the third quarter of 2019. That was a threefold increase over the same quarter in 2018. The total number of direct exchange transactions was over 1.2 billion in 2019. That's an average of 68 million per month. What's interesting is the use cases range from the bidirectional referrals to automated patient summaries for emergency department visits, automated push event notifications, or those alerts that we were talking about in some of the earlier sessions. Those are usually triggered from the ADT, or the admission, discharge, and transfer messages, and the bidirectional patient messages. So again, when we are setting up an HIE, we know that direct is going to be an important part of the overall solution and the transport and notification methodologies that we're going to use. So here's HL7 from the very beginning. And I honestly would have to think back to what year I had to actually set up an ADT interface. But it's currently known as patient administration, which really makes a lot more sense to me, because you don't necessarily admit or discharge or transfer a patient in outpatient setting. But the ADTs basically create a real-time message that sends information over from one system to another system, notifying or sending information that talks about an admission, a discharge, or summary. The patient administration standard defines the requirements and specifications to support the interoperability among the clinical and non-clinical systems regarding patient encounters and administrative registries. ADT interfaces have been set up among different systems within the same healthcare organizations for years. Examples to that would be a lab system that is not an integrated part of your electronic health record, or patient monitoring systems like telemetry, nurse call monitoring systems as well. So we've been seeing ADT interfaces out there for quite some time. When we talk about the HL7 clinical administrative domains, we talk about their messaging standards. And again, if any of you want to see some of the nitty-gritty, pull out some of the HL7 implementation guides and look at the detailed information about the structure of each and every one of the records and the fields within those records that are being transmitted. But there are standards for submitting electronic laboratory reporting to public health, syndromic surveillance information, simple things like height and weight reports. laboratory results interfaces, like we talked about, and many of those are really important when we talk about quality measures, healthcare quality improvement. We also have the orders and observations, which can include radiology as well. And then just for fun, because I know I have some geeky friends who like to talk about genomics, there's also a standard for transitioning or transferring information around clinical genomics. So there's also an important piece of the puzzle under the Clinical Document Architecture, or CDA. It's a document markup standard that specifies the structure and semantics of the clinical document. So it's a document, the CDA document is really defined as a complete information object and can include text and images, sounds, and other multimedia content. The document can be sent inside an HL7 message that can, or can exist independently. It can be outside a transferring message. So sometimes we're saying we're able to do some interfaces with our organizations that are strictly HL7. Sometimes we're able to do just the transmission of the clinical documents as well, and we're using a clinical document architecture structure. So the bigger picture is that you may be able to receive more information via the CDA than you could just the generic HL7 interfaces that may be being implemented. So again, it's going to be interesting as we roll forward to bring in the information and to be able to double check the integrity of that information because again, there's some normalization and mapping and other things that are going to need to be done. So there's also an acronym called CCDA, and it's short for the Consolidated Clinical Document Architecture, and it's a specific type of a clinical continuity of care document, or CCD. See, even all these acronyms get me confused. So the CCDA, or Consolidated Clinical Document Architecture, has been adopted as an industry standard for creating patient care summary documents. What makes the CCDA significant and an improvement on the previous standards is that the data exchange is machine readable, so it can be picked up by HIE systems and parsed out into patient records. It's also a consolidation. It's not a single document for a single visit. It is a consolidation of multiple sources of the data. So I think it's also important to understand that this format was specified as a requirement for stage 2 of meaningful use, and the information that can be included in the CCD would be the patient demographics, the patient history, medications, allergies, procedures, encounters, problem lists, diagnosis, lab results, immunizations, and health risk factors. The CCDs can also include advanced directives, family history, social history, and insurance information. To meet the objective for stage 1, it required that sending them outbound from an electronic system was one of the measures that we had to meet. So there was also a limited data set, so it would only have to include the allergies, medications, and lab results along with the problem list. And then they expanded that when we hit stage 2 of meeting. All right. Those of you who are having fun with some of your data submissions to NIPS or other quality reporting probably know about the Quality Reporting Data Architecture, or QRDA, which is the data submission standard for the variety of quality measurement and reporting initiatives. The QRDA creates a standard method to report quality measure results in a structured, consistent format and can be used to exchange electronic clinical quality measure data between systems. QRDA is an HL7 standard, and based upon one of the CDA-based standard, and it was adopted by the Office of the National Coordinator as a standard to support both QRDA Category 1, or individual patient reporting, which is an individual patient-level report, which can contain quality data for one patient or one or more measures. It also supports the Category 3 provider aggregate data, and that is expanded to support the exchange of promoting interoperability measures and improvement activities for the CMS Quality Payment Program, QPP, which is what we report MIPS under. So the QRDA 3 report contains quality data for a set of patients for one or more clinical quality measures, and can include promoting interoperability measures or the improvement activities as well. In the event that Big Sky Care Connect wants to aggregate quality data that may not be included in the other data feeds, a QRDA becomes another source of quality data to complete the quality picture. All right, let's talk about healthcare on fire. So the FAST Healthcare Interoperability, I can't even say it now, Interoperability Resource Standard is mainstream. I didn't realize that FHIR is the best known health IT standard on the market today. It actually mirrors that messaging of the HL7 version 2 and the organization's first information exchange standard, which was usually what we started out doing all of our initial HIE interfaces under. But unlike its predecessor, it supports a multitude of transfer mechanisms, such as an HTTP-based transfer and the HL7 minimum lower layer protocol, which is also called the MLTP. So it gives us a lot more flexibility, and it's very versatile, and that's what's considered one of FHIR's best strengths. According to the HL7 solutions modular components, it can be assembled into working systems that solve real-world clinical and administrative problems at a fraction of the price of the existing alternatives, or those HL7 separate interfaces that we were talking about previously. FHIR is suitable for use as in a wide variety of contexts: mobile phone apps, cloud communications, electronic health record-based data sharing, and server communication in large institutional healthcare providers. So according to the ONC in late 2018, 32% of health IT developers certified their solutions were using FHIR, specifically FHIR Release 2. Slightly more than half, or 51%, appear to be using a version of FHIR combined with an authentication protocol called OAuth 2. However, further analysis revealed that 82% of hospitals, 64% of physicians used FHIR-enabled products from this third of the health IT developers. Part of the reason it's being adopted is it is actually a requirement now for certified EHR technology. So that has definitely helped with the adoption of the FHIR standard. And with an eye to the future, everyone should consider looking up the United States Core Data for Interoperability, or USCDI. It is an up-and-coming standard that is a health data class standardized set of constituent data elements. Basically, it's kind of like taking up some of the standards that we have, reshuffling the cards, and laying them out in a little bit better order to help with a nationwide interoperable health information exchange. Again, a little bit ahead of its time. Actually, we're not ahead of its time, but it's not ready yet. So we'll be talking about more of that the days and weeks and years to come. Okay, I think I need my 7th inning stretch now. Data capture, validation, and completeness. So this one's going to date me, but I want to know who remembers Steve Austin. He was the Bionic Man, which was a TV show in the 1970s. Every show started with this quote: Steve Austin, astronaut, a man barely alive. Gentlemen, we can rebuild him. We have the technology. We have the capability to build the world's first bionic man. Steve Austin will be that man. Better than he was before. Better, stronger, faster. So just to be clear, I was really young then, and I was only watching it with my older brothers. But what you say does this have to do with EHR and HIE data? Not too much, but it has become my mantra for HIE version 2.0 in both Wyoming and Montana. So better from the lessons that we learned from versions 1.0 and from the collaborative HIE partnerships around the nation. Stronger because this is no longer the cart before the horse in either state. We have the certified EHRs now implemented across our states, and we were able to use the standards that have evolved and improved. And faster with amazing new technology and cloud services, as well as current and future improvements in broadband coverage in many of our rural communities. All right, everybody wants to know that entering data into HIEs, well, entering data into the EHRs should be simpler. Lean principles tell us that we should be able to do something once and reuse it many times. It's the same with the data. We should be able to enter information one time for the patient and report it across the entire clinical realm of data. So if my temperature, because I had to take it today to make sure I don't have COVID or something, when I record it in one place, it should be available many places. And so we've seen over the years that too much flexibility can be a bad thing, because in some of our organizations, our providers who wanted specific customizations may have asked for a specific assessment, and that specific assessment may have duplicated the same data that was being gathered and entered by a nurse or someone on check-in of the patient. So always remember that our goal would be to enter the data once and use it many, many times. Data validation is always a challenge, and that's my challenge to our health information management folks as well, is what do we do to review the data to confirm the integrity of the data regardless of what system it's in? When we connect systems internally within a single organization, what do we do to validate that data? Well, obviously we have to find a way to review the data from a source system and a destination system, or we have to verify the data from where we're entering the patient information to maybe the patient list by condition report out of your EHR, or the clinical quality measure in your EHR, or the patient dashboard. Regardless, it is really important and critical that we be willing and able to review the data, and also to think about doing it after changes in the system. So anytime we put on updates or upgrades, we probably have to start at the beginning and review that data again. Checking for missing data is always important. A lot of times that's what impacts some of the quality measures that we're working on. If we haven't recorded the flu shot in our EHR and we can't pull that information in from an immunization registry or through our health information exchange, that might be something that we have to enter manually. What about the A1Cs that might be missing? Did someone actually have that? Did they have blood work drawn at a health fair? Did they have information that came from some other source that may have been scanned in, or part of a fax that is not discriminate data within our system? We always say run the reports, whether that's the dashboard, whether that's the quality report, whether that's the attestation reports. It's important to review those and to check and double check before it's time to actually report the data. I always say trust but verify. I don't send anything out without looking it over once or twice and potentially having others who are knowledgeable on the information that's being reported look at that data as well. Okay, so my lesson from today is complete data comes from many sources. Sometimes those sources are all integrated within a single EHR. Sometimes those sources come from across the healthcare organization. Sometimes those sources are from across the state. As we move forward, it's going to be interesting to find out how much data will we actually be able to populate to our centralized clinical data repository at Big Sky Care Connect. Okay, when I was researching the history of healthcare quality reporting, I found a very interesting blog at Definitive Healthcare, and I'm happy to share the link if anyone's interested. What I thought I would find, while I thought I'd find several years of history, I didn't think I would learn that quality improvement initiatives have been in place in healthcare for at least 200 years. In 1846, for instance, a Hungarian obstetrician named Dr. Ignaz Semmelweis, I'm sure I butchered that name, became an early proponent for hand washing to prevent the spread of disease and other healthcare associated infections. A big part of what Mountain Pacific has done over several years is to work in nursing home and other places on healthcare associated infections. And of course, I can't help myself but taking the opportunity to remind everyone to mask up and soap up as we continue to battle COVID-19. So my history with healthcare quality reporting programs is limited to the last decade, when I was introduced to some of the value-based programs. These are important because they're helping us move toward paying providers and hospitals based on quality rather than the quantity of the care that they give patients. As we know, sometimes it's 20% of our patients that are receiving 80% of the care. So as you can see, value-based programs reward healthcare providers with incentive payments for the quality of care they give to people. This says with Medicare, I say with other payers as well. That's why we're going to continue to see new payment models come out. The programs are part of a larger quality strategy to reform how healthcare is paid and for how it's delivered. And the value-based programs support the national, okay, this is a three-part aim. We do know that it's probably going to be 4 to 5 parts moving forward, but that includes the better care for individuals, the better health for populations, and the lower cost. And I'm sure that once we get through COVID, we're really going to see the part about the resiliency of our providers who are working so hard to take care of us and our families in this trying public health emergency. So originally, there were 5 value-based programs. Some of these are still in effect. Many of these have changed, and of course, many have expanded. I've had the privilege of working on a few different hospital improvement programs through our national associations and many of our hospital associations. We had hospital improvement programs at various levels. One of the important ones that continues on is the Medicare Beneficiary Quality Improvement Project, or the EQIP reporting. And then obviously there are also state-specific reporting programs, like I talked about, our chronic disease prevention work that we're doing in Alaska, Hawaii, Montana, and Wyoming. All right. I promise there's only a few more slides left, really. Data exchange and data sources. As I said, we need to make sure we have standard data in our data sources, which helps maintain the data integrity as that data becomes transferred or transmitted to other systems, whether it be an HIE or whether it be other internal systems as well. So we talked a lot about the HL7 interfaces, including the admissions, discharges, and transfers. We talked a little bit about direct and the push notifications that will probably be an important part of the alerts and notifications that we'll be utilizing. And we've also talked about the fast healthcare interoperability resources, which are very modular and very versatile and take a lot less time, a lot less expense in their implementation. Our data sources are always going to be changing, but one of the things that I think will be very important as we start standing up the HIE in Montana would be to make sure that we are able to utilize the algorithms for accurate patient matching. Patient matching data can come from many different places. This is something that I learned in part of the procurement we've been doing for the products at Big Sky Care Connect. And when we think that, oh, we're only going to be looking at the patient data from health records, why not look at other patient matching data from credit bureau, from systems that list out who has benefits from different payers. There will be several places that we're going to be able to get patient demographic, patient matching information from. So obviously we have the EHRs, we have claims data, and we haven't talked a lot about claims data, but a lot of times the claims data can complete or actually show us big gaps in some of the care. An example for that would be drugs that get prescribed, but the prescriptions don't get filled. And we also know that right now the social determinants of health are critically important and probably more important every day as our pandemic continues. So I did want to briefly mention that Big Sky Care Connect is going to implement Health Term, which is a terminology management platform from CareCom. And the reason this is important is, again, we want to make sure that we are starting with apples and transmitting apples or oranges. And some of that has to be done with verification of the terminology and potentially some mapping. So the terminology management tooling and distribution Health Term product is a terminology platform for the international healthcare sector. So again, when we talk about the systems that are being selected, we're doing this with the big picture in mind. They call it a platform. Health Term can handle all tasks related to terminologies, code systems, and structured content, from creation of a new code system to translation of international code systems, from mapping between local code lists and international standards. Again, I think it's important to have that thought process of not just being U.S.-centric, but being global because of the amount of hopefully returning tourism that we will all have in our states very soon. So again, to me, for the quality reporting, it's bringing the data together for a big picture, a complete picture. So, if we're sitting in a independent provider's office, and we may see that person, depending upon who they are, once every 5 years, once every year, or maybe it's one of those 20% patients that we might be seeing once every month, or someone with chronic conditions that we might be seeing more frequently, but not during a pandemic. Where is that information, and what information is critical to the best care of that patient? Again, we can find many of these things better as we share more data amongst our healthcare providers across our state. Care coordination is obviously very important, and we had a wonderful presentation on that this session earlier. And referral tracking is also something that has come up in my work recently regarding folks who are referred out for some specialty care, and they seek not to get that care unless they receive a little bit more encouragement from their providers and or care teams and or families. Also, when we look at data, sometimes in our single EHRs, we might show gaps in care. But if you look at a bigger picture by pulling down a consolidated document from an HIE, like Big Sky Care Connect, maybe that missing hemoglobin A1C test has actually been performed elsewhere. And that helps us know that there is information and we can provide the best care to those patients that we are working with at the point of care. So Obviously, we'd also like to look for missing immunizations and sometimes the annual screenings or exams. I'm sure there are several other gaps in care that we can talk about, and also, best ways to share this information across care teams. And again, some of our work, especially in the rural areas, are expanding our care teams for complementary services to our patients. Interesting bit of information for me was the number of times a pharmacist sees a patient versus the number of times the provider may see a patient. But as you add care managers and other folks into the care team, everyone is interested in the big picture of what is in the best interest of that particular patient. So patients, more data, my opinion, is better. We've also heard this morning about how the HIEs have been using their data to help identify patients, some patients with maybe pre-existing conditions who are going to be at risk with COVID. Also, the complications that may arise if that patient has COVID and now some of their chronic conditions are exacerbated. We also can identify folks with food or housing insecurity. I love the story this morning about HIE, Nebraska Health Information Exchange, being able to help route school buses to deliver meals to students who may not have received food because they weren't attending school. It's those types of abilities, that type of information that I think become critical, not just today, not just tomorrow, but in years to come. All right, so when we talk about quality reporting, for me, the more accurate data, the more complete data we have, the better care we can provide our patients. Here are some of the data quality reporting programs that we have discussed, and HIEs are able to report to these different quality reporting programs. Again, some of them may require a little bit of supplemental information data, and we can't wait to start helping folks look at the bigger picture consolidated data and how we could position Big Sky Care Connect to do some of the quality reporting that uses that complete data from their system. So here's one for you. Analytics vendors can also be certified to report electronic clinical quality measures. As I've been reviewing some of the proposals for Big Sky Care Connect analytics and quality reporting, I've done a little research. This is from the Chapel website. You can jump out and see of the vendors that we're talking to, which ones report quality measures and are certified to report those quality measures, and what measures they are certified to report. I of course had to pick KPI Ninja because I'm originally from Nebraska, so go Husker volleyball. That's important. All right, we are also looking at what it will take for Big Sky Care Connect to become a qualified clinical data registry, or a QCDR. I would say that I've heard it's not easy, but it's not impossible. And it is one of the things that I think will differentiate Big Sky Care Connect from some of the single vendors that are out in the marketplace right now, and potentially just consolidating information for a single organization or a single healthcare network. All right, I did want to let everybody know that the Big Sky Care Connect procurement team is currently reviewing and scoring proposals from seven different vendors for the analytics and quality reporting platform. It's really exciting, also very time consuming. And as I promised, there is an acronym list for those of you who don't like alphabet soup. All right, that concludes my presentation, and I will do my best to answer questions, if I can remember how to go find the chat box.
Thank you so much, Deb, and thank you all for attending today. I don't see any questions right now, but if you have questions, I would encourage you all to participate in our Q&A today at 4:30 with all of our Big Sky Care Connect experts online. Hopefully you'll have a nice break, and when you come back at 2:45, you'll be able to learn about how the HIE can be utilized in a pandemic, or you can become informed about our emergency department alert system. So have a great break, everybody. We hope to see you back in 15 minutes. And I did post the Big Sky Care Connect website in the chat. We hope you'll go out there and get connected. Deb and Justin, thank you so much for your excellent presentations and being part of our program today. Much appreciated.
Thank you, Kurt. We appreciate the opportunity.
And thanks, Justin.
I guess I did need that extra time.
Hey, well, that's why I saved it for you.
Thank you.
Thanks, everyone.
Thank you.